I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. According to a 2024 study from the University of California, San Francisco, roughly 1 in 8 older adults in the United States are diagnosed with and affected by traumatic brain injury, known as TBI. Typically a result of falls, crashes, or being struck by something, these injuries can impact both short-term and long-term brain function. So how exactly do they impact cognitive decline? Joining us today to discuss the connections between TBI and cognition is Dr. Daling He, a postdoctoral research associate at UW's Cognitive Communication in Aging and Neurogenic Disorders Laboratory, known as CCANDL. In 2025, Dr. He and researchers from CCANDL conducted a study investigating how traumatic brain injury is associated with cognitive speech changes linked to Alzheimer's disease, before presenting these results at the 2025 Alzheimer's Association International Conference, where you did make a lot of news, Daling. So welcome to Dementia Matters. I'm very excited to have you. We've given a brief definition in the intro for TBI, but can you define what TBI is a bit more for our listeners?
Yes, thank you very much for having me here at Dementia Matter. So, TBI or traumatic brain injury usually refer to the damage to the brain caused by an external force like a fall, a blow to the head, or car accident, or sports clearance. It can lead to temporary symptoms like confusion or disorientation, or more lasting effects such as memory problems or long-term cognitive decline or changes in behavior.
So that's a great full definition. Thank you. And so now I'm wondering, though, especially when you mention sports, how is TBI different from having a concussion?
Yes, that's a really great question. Think TBI is more like an umbrella term, and concussion is type of TBI. It is generally considered a mild TBI. The brain has been jostling, causing a temporary disruption in function, but often without major structural damage in the brain that can be seen on standard imaging like an MRI. But TBI is the broader term that includes everything from a mild concussion to more severe injuries involving bruising, bleeding, or long-term damage to the brain.
You mentioned something that really caught my attention. That was the structural changes that we can actually capture on imaging. Do you have to have structural images or structural change, I should say, captured on an image in order to have TBI? I think of like TIA and how that's different than a stroke, is that in stroke we actually see the evidence on an MRI, whereas in a TIA we just don't see it. I'm just wondering, like, is that a part of the criteria for TBI?
I don't think it's part of a criteria for TBI. Which means it's not all the time the cases that you can observe the structural changes in the brain. Those usually be the severe TBI if you can observe structural changes, but for mild TBI like concussion or just a fall, sometimes you cannot find the direct evidence from the neuroimaging.
And you know what? That makes a lot of sense because I'll see a lot of patients who clearly had more than a concussion, traumatic brain injury, and it was years ago. But when we look at their MRI, it looks totally normal. And so we don't actually see that. And I know that MRIs, we're as good as our tools and it's not perfect, but we don't see it. So I guess that fits what I see in the clinic too. But I'm also wondering then, what are the most common ways people incur a TBI? We mentioned some generic things like falls and crashes, but is that the most common?
Yes, definitely. Falls are the leading causes, especially in young children and older adults. Car accidents, sports injuries like the American football, soccer, and hockey, those are very common for the sports clearance. And combat related injuries in veterans are also common sources for TBI.
Oh, wow. Okay. And so, with all of that context, and now I'm going to go back to a question I always like to ask, which is why did you decide to study TBI and then study TBI in the context of Alzheimer's disease?
This study actually was initially led by Olivia Golet, who is excellent master student and graduated earlier in the spring from our lab, together with Dr. Kim Mueller, my mentor. I also mentored Olivia on this project since I joined the lab. But the reason what we want to study TBI in the context of Alzheimer's because we are fascinated by the connection. Both TBI and Alzheimer's are known causes for dementia, and they may have more link than we once thought. So we now know that the long-term effects of a TBI can lead to brain changes that look very similar to the hallmarks of Alzheimer's disease. Specifically, it's the accumulation of amyloid beta and tau in the brain. So this leads to our key research question. If a person already has these early Alzheimer's pathological changes in the brain, does a history of TBI act as an additional hit, making their decline in cognition and language faster or worse? So that's what we set out to explore in the study.
Oh, that's a great question. That's why I'm looking forward to going over your results. But before we do, how, because I think a lot of our listeners, I'm sure they've heard of TBI or traumatic brain injury, but we also hear a lot of more about CTE or chronic traumatic encephalopathy. How are those things different from Alzheimer's disease? Because they are separate processes.
Yes, that's a really good question. The simplest way to think about it's the cause. TBI is caused by external force to the head, and it's an event. But on the other hand, Alzheimer's is a progressive disease, develops from within the brain over time. And while both can lead to dementia and involve the buildup of the proteins like tau, how and where they are built up is different. So in Alzheimer's, we know those proteins accumulate in a very specific pattern, typically starting from memory centers. But in contrast, the long-term effects of TBI, sometimes known as the CTE, the chronic traumatic encephalopathy, it involves different pattern, especially the tau pathology. The tau often cluster around the brain's small blood vessel and in the deep areas of the brain sulci. This is usually uncommon for the brain that are without repetitive brain trauma. So this also could lead to different symptoms like impulsivity and mood swings, and they also sometimes appear earlier in life than typical Alzheimer's disease. So in short, they have different causes and different brain patterns and often have different symptoms, even though they can have a lot of overlap in symptoms and in the protein accumulation.
That was a great explanation. I'm not going to lie, I was a little bit nervous about it because I recently was at a community event and someone asked me this, and I gave a similar answer. Yours is better, but I wasn't incorrect. And one of the things I want to confirm, because I want to make sure that I go forward with the right information, because I absolutely understand the symptoms can overlap. They can be different too, but they can overlap. And then the protein part, that's where I was getting at. So both conditions, traumatic brain injury, CTE, and Alzheimer's can have the tau protein, that tauopathy. It's a slightly different tau, is my understanding, but it's tau there. And then, but only Alzheimer's would have the amyloid. Or am I right in saying that? Would someone with CTE or traumatic brain injury also have elevated amyloid because of that, or would that just be co-pathology where both processes are happening?
I think there is a lot of controversy findings regarding the amyloid accumulation in the brain. Some of the studies find there is accelerated or increased amyloid accumulation following TBI, but some doesn't. But there is a very recent study find out that it's not necessarily the global accumulation or the global cortical accumulation of the amyloid is increased after TBI, but more like the pattern of the amyloid in the brain is different. And they kind of find following TBI, there is more amyloid and tau related accumulation in the frontal and parietal regions in the brain, which is usually seen later in the Alzheimer's changes, like which means in Alzheimer's disease, frontal and parietal tau accumulation occurs later in the disease progression, but they can find this very early. It followed a TBI history.
Oh, see, that's fascinating. I'm glad we kind of touched on the controversy within the field. So we don't know fully yet, so it's still being explored. But that is very interesting, and the importance, right, of biology and studying this with our biomarker tests, and for our participants to come in so that we can study this over time. All right, so now getting back to your study, what exactly did you find? And now that we know what you were looking for.
Yes, so prior research has established that in individuals with preclinical Alzheimer's pathology, which means they aren't yet showing noticeable cognitive symptoms, but the brain changes related to Alzheimer's already occur. For those people, they experience faster declines in their language ability. And our study extended these findings by showing that a history of TBI can further worsen their language abilities. This effect is detectable even in 28 to 36 years after the brain trauma. And specifically, we saw that these individuals with a prior TBI showed a faster decline in their speech fluency. They spoke more slowly, they used fewer words, and had more pauses and repetitions in their speech. So, this suggests that a past head injury may specifically weaken the brain's language network, making them more vulnerable to the effects of Alzheimer's pathology.
Wow, that's incredible, and you know what? We do actually see that in the clinical setting too. I don't think I've ever attributed it to the prior traumatic brain injury, but you've answered one of my other questions, which was timing. Like, can you have a brain injury 2 decades ago and now have it affect you? And so, I guess one of my questions, because you are in this CANDL lab and you're really looking at communication, what does longitudinal decline look like when it comes to a person with these cognitive and language changes? Like, what might people actually be experiencing? If you could give us some more examples so our listeners know what this might feel like.
Yes. So the longitudinal decline simply means that the changes we observed when we track a person's ability over many years. It's considered a more sensitive matter than a one time test. In our study, people with a history of TBI showed earlier and faster declines in their language related ability, like speaking less fluently or finding words more difficult. It's like aging the brain faster in specific areas, even if overall cognition still seems intact.
And what do these results mean for people who have had a traumatic brain injury, but don't yet have any signs of Alzheimer's biologically and are not showing cognitive decline? Are they just simply at higher risk?
Yes, I think other than the high risk, I think the key takeaway for our listeners is the awareness and proactive management. This shouldn't be a cause of panic, but like more for empowerment. If you've had a significant TBI, it means you should be more attentive to your brain health. It's a reason to work with your doctor on monitoring your cognitive and language function and to adapt a healthy brain lifestyle, as these protective actions may be even more impactful for you, for the person who experienced the TBI.
Are there scientists who are looking at, because you talked about the controversy, so are there scientists looking at whether or not TBI actually induces amyloid? You talked about acceleration or induces tau or maybe leads to an earlier onset as to when someone develops amyloid. Like, are there people looking at the timing of this, or do you know ahead of time now what that relationship might be?
Yes, and the accumulation of amyloid and tau is kind of very critical piece for our study with TBI in the context of the Alzheimer's. So some of the studies have been reporting that a single moderate to severe TBI can trigger a rapid and acute increase in both amyloid and tau protein in the brain almost immediately after the injury. However, in most of the cases, this clears up and they recover within like 3 months. But the theory is that for some other, the injury may last and have a long-term impact. They may prime the brain, making it more vulnerable to the abnormal accumulation of those proteins again later in their life, potentially initiating a neurodegenerative process. Which is very different from traditionally how we think of TBI, which is a one-time neurological disease.
I mean, this is fascinating, and this really makes it actually more complicated, the relationship between TBI and Alzheimer's, which is important for us to figure out. And it actually fits into my last question for you, which is always trying to bring it back to our us as humans and what can we do to stay as healthy as possible and prevent some of these things. And so for you, when you explain your research to family, friends, what do you say when they inevitably ask you about ways to reduce the risk of TBI? What are the key tips you tell them? Or if they've had a TBI, what do you tell them they should be doing to actually, prevent these future things or delay these future things from happening?
Yes, absolutely. TBI is now considered one of the 12 modifiable risks for dementia. So, first, prevent the injury. So this is the most straightforward step. Always wear your seatbelt, use a proper helmet for activities like biking, skiing, or contact sports. And also for those people who are slightly older, make simple home safety changes like removing tripping hazards to prevent falls. And second, respond correctly if injured. This one is crucial. If you hit your head and experience any symptoms like confusion, dizziness, or nausea, don't try to tough it out. See a doctor, get a clear diagnosis, and give your brain the time it needs to fully heal before you return your normal activity. And last, I think it's very important to build the brain's resilience. Think of building a cognitive reserve that you can do this by staying socially and mentally active through conversation, reading, and learning. These activities directly exercise the neural pathway you use for communication and thinking, which can help your brain better withstand challenges later on.
Well, Billing, that's a wonderful way to end. Those are fantastic tips, and we'll have those in our show notes too. But thank you so much for coming on Dementia Matters today, talking about the study you conducted, your presentation at AIC. And I certainly hope this becomes a publication for you. I think it's fantastic work, and I look forward to seeing what else is to come. Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen, or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Caitlin Rauwerdink and edited by Alexia Spevacek. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.